Hello. Well, good morning. Still morning. Yeah. My name's Yafeng Li. I am. I don't think my little brochure there has sort of my background. I'll tell you a little bit about my background first. So I was born in China, and my parents moved here when I was 10 years old, and we moved to the Philadelphia area, where I did virtually all of my schooling. Middle school, high school, college, what have you. And then medical school was at the University of Pennsylvania in Philadelphia. And I did an MD and a PhD combined degree program, which took me 9 years, and which is a 4+5, that kind of combination. And then did internship at the hospital of the University of Pennsylvania in general surgery, and then did a residency in ophthalmology for 3 years at the Shea Eye Institute, University of Pennsylvania as well. And then after that, I did a 2-year vitreoretinal surgery fellowship at the New York Eye and Ear Infirmary in Mount Sinai in New York City in the East Village. So here I am working at the Beth Israel Deaconess Medical Center. It's a great place to work, and we're affiliated with Harvard Medical School right next door. And so besides, taking care of patients, I do a little bit of clinical research, and I teach Massachusetts Eye and Ear Infirmary second-year residents who rotate through our service. And also I teach the medical retina fellows at the institute next door, which is the Joslin Diabetes Center. So that's sort of the scope of what we do at BIDMC, the main campus. And as I was explaining to one of you a little bit earlier, we'd love to kind of expand, to reach out. But so at this time, it's a little bit harder to kind of push retina all the way into the suburban communities because of what the equipment is required for retina surgery. But just to sustain myself, we need 3 types of lasers. We need gas. We need OR time readily. We need exam rooms. We need just all sorts of things that, smaller suburban sites can't accommodate. So that's why for these academic centers who we're primarily focused on Boston right now. So that being a drawback. Anyway, so that's a little bit about myself. So I wanted to talk a little bit about age-related macular degeneration. It's a disease that often is referred to as macular, and basically it affects a lot of us as we get older, and it's a disease that is quite devastating to put it bluntly, and but there are ways we are developing more and newer treatments for it, and we're finding that in our experience over the last couple of decades, I would say 2 decades or so, that this disease, we've reined it in. People are no longer losing sight in a dramatic fashion like the way it was before. So just kind of, I wanted to make this talk relatively easy to understand. So kind of just some, knowledge, background things to talk about. So what does it look like to you? This is, initially, everything is good. Then, early, intermediate, advanced. You can see that you start to lose that central vision. The fine details of what you're trying to focus on becomes blurred out. And so, imagine, this is your grandchildren or, a lovely child of a neighbor. You want to talk to them, and then, essentially you just can't see what's happening with kind of the fine details that you're most interested in. And so, what are the risk factors for age-related macular degeneration? From now, I'll call it AMD, just for short. So age is one. Women are a little more prone to having this condition. High blood pressure, high lipids, heart disease, it turns out, is correlated pretty strongly with macular degeneration. Family history plays a huge role. And that means certain genes not one singular gene, but certain genes confer a high risk for developing this condition. Smoking is a big factor, so I advise you to stop smoking as soon as you can. And then having some sort of inflammatory disease, like elevated C-reactive protein, which is a lab marker that often your primary care doctor will get for you if there are signs of inflammation. So inflammation plays a role in AMD as well. So if you're hyperopic, meaning you've been good with your eyesight at distance for your whole life, but you've always needed a little more help reading, looking at near, that apparently confers a risk too. And also in the bottom here, light iris and light pigmentation. That means like Caucasians are a little bit more prone to this condition. So we talked a little bit about genetic, right? So there are some, I don't want you to be bored or scared off by these big like bunch of alphabet soup type of things, but suffice it to say that there are these two highlighted ones, CFH and ARMS2. These are two gene names, and certain changes in the DNA code in those genes confer higher risk to developing AMD. But there is genetic testing available for it, but the utility of that is very limited. Okay, so the American Academy of Ophthalmology doesn't really recommend doing that because it's not really going to change management or stratify how you think about the condition. So they don't think it's worthwhile to be widespread use to test for AMD genes. At least not yet, not until we really understand how they confer the risk. So talking about the macula, AMD is a macular disease after all. The macula is the very center of the back of your eye. The retina is the neural tissue. It's an extension of your brain that allows you to sense light and see. The macula is the very center of that. And so it's responsible for your central vision, and it's got tons of this good stuff, lutein and zeaxanthin, which is rich in green leafy vegetables. And so that stuff gives the macula a little yellow tinge, the yellow color, and that gives the name of the macula itself, macula lutea, the Latin name for it. But overall, that's what the macula is. And so here's another kind of picture of the macula. Here is your optic nerve. That is the cable that connects your eye to your brain. These are the blood vessels that you can readily see. These are the retinal blood vessels. Superimposed on this picture here are concentric circles that tell you the different zones of the macula. So suffice it to say, if you have a problem right in the center, in zone A, then that really harms your very central, highest acuity vision. So don't be worried just yet, just a sense, just kind of a sense of what the retina is like. So I gave you a view earlier, straight on looking at. So this is a human retina, post-mortem. What does it look like if you stain the section as a cross-section? If you imagine the retina being a cake cut in cross-section, this is what you'll see. 10 different layers of cells, highly specialized. And where do we think macular degeneration starts? Like what layer of the cells does that affect first? We typically think it's the very outer layer, the RPE. Right here in the RPE Bruch's membrane layer is where we think the disease for macular degeneration really starts. This single layer of cell, RPE, begins to get fatigued, gets tired. It's no longer able to clear the debris that the whole cellular machinery in your eye makes over your wonderful lifetime. And so at a certain point, it starts not being able to clear all the cellular debris, and deposits start forming in the outer part of the eye. And so those are what maybe some of your doctors have told you about, which is the drusen. The drusen, the outside deposits that people talk about, and that is a sign of dry macular degeneration. And we'll get to that in a moment. And so here is a picture. You wonder what black and white picture. So this black and white picture, is a better way to visualize it. So no way can we look at this when you come into clinic, right? Because this is clearly a sample from pathology, a post-mortem sample. How do we look at in vivo? You as a patient coming into clinic, we need to see what the outer retina looks like. So this is just a machine. It's called an OCT. You sit there with your chin on, and similar to a slit lamp exam where you're being examined by the eye doctor, same thing, sit there, and a little scanner goes past your eye and gives us an image like this. This has been a revolution in terms of eye care, in terms of a retina, because it allows you to see truly in a living person what the retina is looking like. Now, this is a very normal retina. There are no deposits and bumps in the outer retina. You see these clear 3-4 lines here delineating the layers of the retina, of the outer retina. They look linear, no interruptions. So, people, I'm sure many of you have heard the term dry AMD. And there are a couple different things associated with that. So drusen, I alluded to a little bit earlier, those are the deposits that you see. Pseudodrusen, we'll talk about that a little more. This is the more kind of devastating aspect of dry AMD, which is called geographic atrophy. And we'll allude to that in a moment. So drusen. Here's another kind of picture of where that outer retina is. So imagine that in vivo picture with those 3 lines that I showed you earlier. So imagine we'll just forget all the rest. Think of what does it look like, even more zoomed in at those outer 2 lines. So you have, this is the RPE cell. It's kind of squarish looking here, and it's got a lot of processes sticking up, and it's connected to all the light sensing cells above it. And below it is this like little membrane here called the Bruch's membrane. And then drusen is going to deposit in this layer. In this layer, they call basal laminar deposits, or deposit within the Bruch's membrane. Suffice it to say, if things start depositing here, you're going to get like bumps in the areas, little bumps around. And so that's cellular debris that's unable to be cleared. And so these are just terminology for kind of different types of drusen, okay? And drusen is a German word that means pebble. So it looks like a pebble, basically. On pebble, yeah. And so some more drusen facts, right? So they can look hard, which means they're like little discrete little dots. When you look at it on the exam, it's little dots. And they can look soft. They can look kind of, without clear borders, kind of spread out. They can be confluent. So, or there are just so many of them that they're connected with each other. So when, you have so much of this kind of confluent drusen, you're going to most likely develop into the atrophy or CNV, which we'll talk about in the wet macular degeneration portion. So here's a look at what the drusen might look like. Here's a zoomed in view. You're looking at part of this is the very center of the macula. Here's a large drusen. It's greater than 125 micrometers. Here's a medium-sized one right there. So these are 2 isolated drusen away from the center. So this is good. This is good. This patient does not have any visual problems at this point. So when you have geographic atrophy, that's, like I was talking about, that's the one with the more kind of visually significant effect. And so in this patient, you can see that, this whole center area is affected, right? And so you see that these red vessels here, they're branching like that. they don't really fit in the pattern of these nice vessels that you see here. These vessels are actually not in the same layer as the ones you're seeing here coming off of the optic nerve, because these vessels are way down below. You shouldn't be able to see them. The reason why you're seeing them is that the RPE cell, that single layer of cell that was there, that's diseased, is now all gone right in the center. So now you have an open window. You have an open window and you actually see the blood vessels beneath the outer wall of the eye. And that's when you know that the geographic atrophy has progressed so much that all this tissue is gone. And so the central vision, as you can imagine here, is not good. And geographic atrophy has been very, very tough for patients because for many, many years, there was no good treatment for it. In the last 2 years, in fact, 2 new drugs were approved by the FDA for this medication. 2 new medications were approved for this indication to treat geographic atrophy. And what it does is that it doesn't recover what you've lost. All it does is it attempts to slow down the rate of loss. And they work to the tune of maybe slow down the rate of loss by 20 to 30%. It's not a dramatic effect. And many patients still feel like, I don't see much of a difference, especially if the disease is progressed to a certain extent already like this. The fact often is, as patients, as humans, when we've lost something and we get all these treatments, they're very burdensome, right? Injections, and you don't really see any improvement. It's very difficult for that treatment to continue because you're just told that it's just preventing further loss. You're not gaining anything back. So those treatments are there, they're exciting, but they're also, not to the extent that any of us would like. So just wanted to kind of present that out there. And those 2 drugs, one of them is called Syfovre, the other is called Izervay. There's lots of excitement surrounding them, don't get me wrong, but they also need to be tempered with the idea that they don't recover what you have lost already. So management. Right. So for years, and this still holds, even with the new drugs, this still holds. Typically, at home, if you're told you have dry macular degeneration, you should really kind of keep, for lack of a better term, keep an eye out, right? So you have your Amsler grid. I'm sure some of you have been shown that. It's a big black dot in the middle, and then it has a grid around it. And you're supposed to test one eye each time at about reading distance or so with your best corrected readers, for example. You can put it on your refrigerator or wherever is most convenient. And you look at that central black dot. And that central black dot surrounding it, the grid, if it becomes wavy, distorted, or if some part of it is missing, then that's not normal. That means that something is changing. Something is changing, that there could be fluid in the retina, there could be new bleeding in the retina. That's a sign that there's possibly a conversion from the dry form to the wet form of macular degeneration. And so, this is a kind of a more, a sophisticated test that some doctors do in sort of more specialized settings where they, do this test and they see if, the examinee, kind of has an issue perceiving sort of the alignment of these dots. But, this is a much harder test to do and much more difficult to administer at home. But the other thing that we emphasize again and again, and, eye doctors, we never really hawk, micronutrients or vitamins around, but this is the one instance, right? For dry macular degeneration, especially the intermediate forms where you have some drusen, but you don't have the atrophy, you don't have the big loss of the tissue yet, we really emphasize taking the eye vitamins, the AREDS2 eye vitamins. And what that has in there is the stuff that is rich in the macula, the lutein and zeaxanthin that I talked about earlier. So this is like packed green leafy vegetables in the AREDS2 vitamins, and that you should really take those if you have any sort of early dry form of macular degeneration. So this is that Amsler grid that I was talking about. You're supposed to focus on that dot and that wavy distortion. While you're looking at that dot, you're noticing that. That's not normal. And this is the AREDS2 vitamin that is sold over the counter. The main thing is that it has the newer generation AREDS2 formula is the one that's sold currently in all pharmacies, and it has the lutein zeaxanthin here. And it got rid of the beta carotene because beta carotenes had a problem with it conferred a higher cancer risk for smokers, especially. So this is gone. This is gone from the market. This AREDS2 is the way to go. So you know the vitamin C, E, and the lutein zeaxanthin are there. So typically this is a little bit complex picture, but just kind of a simple summary is sort of how do we grade the risk of macular degeneration when we see a patient with dry AMD in the clinical setting. We look at their exam, we look at the OCT pictures, we say, the question then comes, what is my risk of developing advanced AMD in the next 5 years? So you calculate the number of points. You have a large drusen, you get 1 point. If you have any pigmentary changes in the back of the eye, you get 1 point. But if you have no big drusen, but some intermediate sized ones in both eyes, you get 1 point. And if you have neovascular or the wet form of AMD, you get 2 points. You add up the points, and here you have the 5-year risk and the 10-year risk. So easy enough to see that with the higher number of points, you have a bigger risk of developing advanced forms of the disease. So that was kind of the dry form, and now sort of the exudative or the wet form of AMD. So we talked about the Amsler grid. You're seeing that distortion, right? You're noticing that's a change for me, right? So that's when you should see your retina doctor as soon as possible, because that could suggest that you're converting to the wet form. And I'm going to take a step back and say, what if you say, okay, it's okay, I'll just wait on it, I'll see. It may be okay for a little bit. You may just notice that distortion, but that fluid that accumulates, that converted to the wet form, that fluid has blood components that should stay in the blood vessel. It shouldn't be in the retina. So when the retina sees stuff that it shouldn't see, it starts forming scars. And so if it's left untreated, scars form in the retina. Imagine the retina is brain tissue, it's neural tissue. It should never have scars in it. So when you form scars, then basically that whole area, the area that's most precious to your vision, the central vision, becomes scarred over, and you lose large chunks of your vision over time. So that's what happens if you don't treat it. You leave it be. It's just a little distortion, it's okay. My other eye's good. I've seen too many patients like that. My other eye's good, this one is not as good. But then when they present to me, the eye that they left without treatment is a big scar. And there's really no reversing of that. Okay. So for the wet form, you see this sudden decrease of vision. This is a fancy word to say distortion. You see the twisting, distortion, and then you see that blind spot in the middle. And what we call that we're worried most about what we call this CNV, which is choroidal neovascularization. It's that vessels from the choroid growing up, forming these membranes here. We're getting these images and we see these abnormal membranes here, and it's showing us that it's leaky, and that on the color photograph you see it's actively bleeding around. And it's obviously affecting the very center of the retina. So, many different types of wet AMD, depends on where the blood vessel is. So there are 3 different types and yet a 4th type that is kind of a variant. All of these, are kind of, I would say, equally threatening to your vision, okay? So, just showing, I adapted this slide for kind of resident teaching, so it's a little complicated. But this is the OCT images to show you the type 1, type 2, and type 3 development. I won't sort of dive into this too much, but you can sort of study the characteristics and know, and once you get a baseline picture and you start the treatment, you can have a better sense of monitoring the response. And not all of these types respond to the medications equally well, and not every patient responds to the same medication the same way. So every person's therapy is a little different in terms of what type of medication, the treatment interval, and so there's a fair amount of variability there. So luckily, it's no longer 1975. We have options now. These things, everything below the anti-complement here is quite mature in terms of clinical experience, okay? I'll talk about everything below here first, okay? So laser photocoagulation for wet AMD. Not something that we do routinely anymore, given, you're doing laser near the very center of the retina. You really have to have a good target, a clear target of one leaky blood vessel, for example. That's where you would laser. Oftentimes, as you can see, as you saw with these pictures, there's a big diseased membrane here. You can't laser this whole area because you'll just damage the whole central vision. So you can't do laser. So we don't do laser as much anymore. PDT is a good therapy that was developed at Massachusetts Eye and Ear. And in some indications, in some diseases, it's still quite useful. For wet AMD, it's used less and less as well. The bulk of the therapy nowadays, everywhere, is the anti-VEGF injections, which some of you are familiar with. These are the official names for them, but this is the earliest generation, tried and true, Avastin, which is bevacizumab, Lucentis, this name, Eylea, this name, and this is one of the newest, it's called faricimab or Vabysmo. All of these target this molecule, VEGF. VEGF is vascular endothelial growth factor. It's one of the molecules that gets secreted to make new blood vessels. When you have wet macular degeneration, you have diseased new blood vessels that shouldn't be growing that are growing. And they've done, years ago, many studies to show that in wet macular degeneration, this molecule there was more of this molecule in the eye. So this became a target for all these subsequent therapies. And they work differently. A little bit different, tailored to different targets of the same molecule. Their antibodies are made a little differently, and some doctors like one for one type of patient, others for others. There's some subtleties with that. But this newest one targets not just VEGF, but targets another pathway that's involved in abnormal blood vessel growth. But suffice it to say, this is what most people are using now. And here are some of the Lucentis is right here, and Eylea, which is the aflibercept, is right here. There's a high dose Eylea that's been recently approved. So that means the intervals between injections can be a little bit longer. That's here. And Vabysmo is this thing, faricimab, that targets 2 pathways. It's here. And this Izervay is what I was talking about way earlier for complement. So it targets something entirely different from any of these. It targets complement. Complement is involved in inflammation because in the dry form, you don't have those blood vessels yet. You just have inflammation. And so that was the basis of designing medications to target inflammation. But like just to kind of recap there, targeting inflammation, this medication only kind of stops the rate of loss. It doesn't really help you regain anything in terms of tissue. So, and these things are very new. I would say the clinical experience of it is not quite mature yet. We have these medications at Beth Israel Deaconess, but, I often, talk to patients like, look, I'm very conservative. I don't like to, these medications, although approved, the experience of it is just not widespread enough for us to know yet. So, if you see your retina doctors, they will offer you this, if they have it available, because it's the newest and greatest. But, for me, at bigger academic centers, I tend to look at these and I say, I really need to see that they are mature in terms of clinical experience, in terms of adverse effects, before I really kind of open the floodgates to using this medication. It's very, very new, okay? Diabetic retinopathy, basically the underlying thing is that you have to have diabetes, right? So diabetes is, as most, if not all of you know, diabetes is a problem with the control of your blood sugar levels. Right? And so it's an endocrine problem, it's a metabolic problem, but because the eye is so metabolically demanding, it requires so much nutrients, its specialty is so, its function is so specialized, I should say, it's really affected by the change in blood sugar levels over the long term. So that's why in diabetic patients, often you have eye problems, you have kidney problems, you have blood vessel problems, you have heart problems, you have nerve problems. All of those are metabolically demanding tissues that are affected by this high sugar environment, okay? So, basics, right? Basics, dividing up diabetic retinopathy into kind of 3 general things we kind of talk about in a clinical setting. There's the non-proliferative type. Non-proliferative just means there's no scary blood vessels growing everywhere. There's no bleeding yet, okay? That's the NPDR. You have mild, moderate, severe, and very severe stages of NPDR. And of course, that can transition into PDR, which is proliferative diabetic retinopathy. It sounds worse, right? And you can have the early form, and there are some features that are really high risk here. And then apart from that, you have DME, which stands for diabetic macular edema. If it involves the center or the macula, it affects your vision more. If it's not in the center, we have some room to observe or manage more conservatively. So, diabetes is just becoming more and more prevalent. And so that's the problem, right? That's the problem that eye doctors are facing, as, people becoming more and more, having more and more metabolic syndrome and more diabetes. So we know that in the Wisconsin epidemiologic study, we know that type 1 diabetics, almost all of them will have some sort of retinopathy after 20 years. So initially, this is a disease, it's a silent killer. You basically don't feel anything for many, many years, even if your blood sugar is totally out of control. And then type 2 diabetics, at least 2/3 will develop retinopathy, okay? So it's really something that, presents often quite late, okay? especially in areas that don't have good enough screening. So, kind of give you a little bit of background in terms of what DR, or diabetic retinopathy, is. Basically, the high sugar level, hyperglycemia, it damages the cells lining the inside of the blood vessels and causes some of the cells to be lost. And then what that happens is those blood vessels clamp down and close off. And then you have areas of the retina that doesn't get any blood flow. And so what we call retinal non-perfusion. The retina no longer gets perfused by blood because those vessels, those small vessels, capillaries, are occluded, blocked off. And so you can see this is one of the newer scans. This is a blood vessel picture of the very center of the retina. This area black is supposed to be there, but it's way bigger than what it should be. So it's a big, large non-perfusion in the center. And that's because a lot of these capillaries here that should be looking like this, that should be here, that should be here, that should be here, they're all gone. They're all lost. And that, remember, is responsible for your very central high acuity vision. When you lose blood flow here, 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 the vision's obviously going to drop. So, there's a lot of recommendations for how often you should be seen if you have diabetes. So if you have type 1, you should be seen at least annually, starting 5 years after your diagnosis. Type 2, you should be seen as, annually at least upon diagnosis. And then for pregnancy and such, there are also recommendations. This is a recommendation from the American Academy. So, of course, it gets into more detail. If you have mild, moderate, severe, basically, won't bore you with this, but based on if you have swelling or macular edema, there's a nice chart, a nice guideline to say how many months should be your follow-up. If you have normal or minimal, not much of diabetic retinopathy, you can be seen yearly with good blood sugar control. But if you can see with high-risk PDR, if you have new blood vessels, and you have swelling, you got to be seen every month. I think this is worth talking briefly about. So, for patients who often present with, severe changes due to diabetes, and they make a lifestyle change, they really are trying to get better with their diabetes control. They get their hemoglobin A1C much better. But, they come back to say, my vision's getting worse. There's more, and then on the pictures you see more swelling. There could even be more bleeding. And why is that? That's one of the well-documented phenomenon. Once you tighten up the control, the body reacts, the eye reacts. So it actually the eye gets worse for some time before it gets better. But that's better than you not controlling your blood glucose levels, right? Because that will give you the benefit long term. That'll help you. So it's in that initial period where we start the intensive eye treatment, but things just keep on getting worse. That could last somewhere between 6 months to a year, something like that. This is the sort of categories of NPDR, PDR. What I mean by PDR is that this looks subtle, but this is like a little tree here. That's like an abnormal blood vessel tree that's gonna bleed. And if you do studies, fluorescein studies, that's gonna leak, and that's where bleeding happens. So the treatment is mandatory for PDR, obviously, because you'll have swelling, you have bleeding in the eye. And anti-VEGF looks familiar. Similar types of treatment because it's still kind of the main problem in PDR as well, in diabetic retinopathy. But laser plays a more prominent role. Surgery comes into play for severe diabetic eye disease. And then swelling is a main indication for injections as well. And so these look familiar to you from earlier. Same medication, but treating diabetic swelling. There's more, sometimes there are special eye steroids that are used to treat these types of swelling as well, but we don't go into that. So I think that's mainly it. Yeah, and here's my contact info. I think Lorraine handed out a bunch of cards. Yeah, yeah, yeah. Okay, thank you.